Well, I'll get started. Well, good afternoon, everyone. Thank you for coming. And I was spurred on to do this topic by Danielle's case last week. And this is a talk I started thinking about 16 years ago. I looked at my first version, but I never gave it. So I'm grateful to have the opportunity to discuss FSGS with you today. So first, disclosures, and I actually went on to the open payments system and saw that I got $150 from Takeda for serving as faculty or speaker. I don't remember getting $150. It was probably for Fabre's dinner, and it seems a lot for rubber chicken, but it is what it is. I'm not going to be talking about this in the slightest today. So we'll begin with a case report. Ms. Y has a past medical history of severe gastroesophageal reflux disease, complicated by nutritional anemia and esophageal strictures requiring serial endoscopic dilatation. In 2016, she presented with severe leg edema, proteinuria, serum creatinine of 1.2, and dyslipidemia. Kidney biopsy demonstrated FSGS, TIP variant. She was put on oral prednisone, 40 milligrams daily, and she went into remission. Her prednisone was tapered, but her nephrotic syndrome features recurred within weeks of being off the prednisone. So the learning objectives today will be to describe the histologic and pathologic classification of FSGS. And I'm doing this despite the fact that the classification schemes are messy at the moment, but we will go through them because it's what you'll read about all the time. Two, to understand the history of primary FSGS, and this is what prompted me wanting to do this topic at this time because there's been so many great advances, and talk about some of the current hypotheses for pathologic mechanisms. And the third is to understand the rationale for current and potential treatments for FSGS. And we'll be doing this all throughout the talk. So first, let's go through some numbers. In the United States, the annual incidence of FSGS is 5 cases per million in whites and 24 cases per million in blacks. Given the Florida population of approximately 23 million, that means there will be 200 new cases annually. FSGS accounts for 40% of nephrotic syndrome in adults and 20% in children. And again, in the US, end-stage renal disease secondary to FSGS occurs annually in 2 per million in whites and 7 per million in African Americans. FSGS is not a specific disease entity, not like IgA nephropathy or encapsulitis. It is a pattern, it's a histopathologic pattern of injury seen on light microscopy. And it consists of sclerosis of a portion, the segmental part of the name, of the glomerular capillary tuft. And in later stages, you have accumulation of extracellular matrix involving some focal, the focal part of the name, glomeruli. And this lesion has heterogeneous causes, but the common initiation event is podocyte damage, which eventually leads to podocyte depletion and glomerular scarring. And hence, FSGS is considered to be a podocytopathy. Now, in an attempt to understand why some cases of FSGS responded to treatment and others didn't, pathologists tried to separate FSGS into different histologic classes. And one of the classification schemes is a Columbia classification scheme, came out in 2004, and is probably the most widely utilized. So first, you can have a collapsing variant where scarring occurs quickly and affects the entire filter, causing it to collapse. And this is the most rapidly progressive form of FSGS. It's typically not responsive to therapy. Next, you have the TIP variant, the variant had by our case, and This is where you see glomerular scarring occurring at the tip of the proximal tubule. This is where the proximal tubule enters the glomerulus. And to call it something the tip variant, you can't have the collapsing variant, and you can't have perihilar sclerosis, which we'll talk about in a little bit. This is the most responsive to treatment, as was seen in our case, and steroids can induce a full or partial remission. Then you have the cellular variant, where cellular proliferation within a portion of the glomerulus leads to narrowing of the capillaries. And this cellular proliferation can be from podocytes, or the proliferation can be endocapillary from inflammatory cells or foam cells, and the foam cells themselves can be from endothelial cells or monocytes. It can only be diagnosed if you don't see tip or collapsing lesions in any glomeruli. Then you have the perihilar variant, where scar forms at the hilum of the glomerulus, where the afferent and efferent arterioles enters the glomerulus. It's most often seen in secondary FSGS, which we'll discuss later, but generally secondary FSGS with the perihilar variant is seen when you have a reduced nephron number and glomerulomegaly. Again, you can't have cellular, the tip, and collapsing variants in any glomeruli biopsied. And last, you have a classic FSGS. This is FSGS or FSGS not otherwise specified, and it's diagnosed if you don't see tip, perihilar, collapsing, or cellular glomeruli on the biopsy. So looking at the frequency of these morphologic phenotypes, the most common morphologic phenotype is not otherwise specified, seen anywhere about 50% of all cases of FSGS. And the collapsing tips, cellular, perihilar, divide up pretty equally the remaining portions, although the proportion of any one morphologic phenotype may be more or less depending on the studied population. When looking at the collapsing variant, a high percentage of African Americans will have the collapsing variant. Here's in this study, it was 69%. Nephrotic syndrome is quite common, 88%. It has the lowest remission rate. And some causative agents are some viruses like HIV, parvovirus B19, mycobacteria, and some drugs like interferon and pamidronate. Then you have the tip variant, which has a low percentage of African Americans, in the study 14, a high probability of nephrotic syndrome, 92%, and the highest likelihood of remission. Then you have the perihilar variant, which again is the variant seen in secondary FSGS associated with glomerulomegaly. And in a study out of Japan, what they did is they used next-gen sequencing, targeted next-gen sequence, to sequence 62 podocyte-related genes in 119 consecutive patients with FSGS classified through the Columbia classification system. And what they found in the perihilar variant, a full 83% of individuals had monogenic disease-causing variants. So even though this is secondary FSGS, they saw most closely associated with secondary FSGS, you saw monogenic disease-causing variants. In the collapsing, you saw 18% of cases had monogenic disease-causing variants, and since this was Japan, this wasn't APOL1. In the tip, none monogenic disease-causing variants were found. Cellular, it was 24, and not otherwise specified was 30% monogenic disease-causing variants. And this 30% is interesting because when we talked about a couple of years ago, next-gen sequencing, you'll find in all CKD, you'll find a monogenic cause in about 30% of all cases. But the central feature of segmental glomerulosclerosis is foot process effacement. And I love this picture because it just shows the beauty of the glomerulus, where you have these interdigitating foot processes from two different podocytes. They come together. And looking at this structure, it's not hard to understand that if the capillary, shown in purple here, expands greatly, or if there's signal or the actin cytoskeleton of the podocytes is disturbed, or there's signaling consequences that are perturbed within the podocyte, that this fine, delicate structure would be lost. And the podocyte structure defines its function. So once you disturb the structure, its function is going to be disturbed, and you're going to get proteinuria. So now we're going to switch to the pathologic classification of FSGS, and Dr. Shaw made this distinction last week with Rick Case. And here you can have secondary FSGS, genetic FSGS, primary FSGS, and FSGS of unknown cause. But I said this classification scheme is really messy, since KDIGO defines primary FSGS as idiopathic disease without identifiable cause. However, KDOKI suggests that FSGS due to known genetic variants should also be called primary FSGS because the effect of the variant is primary damage to the podocytes. To complicate things further, many restrict the term secondary FSGS only to hyperfiltration form of FSGS, where you have segmental foot process effacement. Yet some, as we saw with the secondary FSGS perihylar variant, will likely have a genetic variant that may worsen or hasten their disease. But given all of those caveats, let's go through and discussing some of the pathologic categories. So you have secondary FSGS, which is just an umbrella term for FSGS lesions caused by a diverse array of pathogenic events. It can be subdivided into maladaptive FSGS, drug-induced FSGS via direct toxic effect on podocytes, and this toxic effects could be due to drugs, bisphosphonates, interferons, and androgens, or viral-induced toxicity, like as seen in HIV, HCV, EBV, SARS, and CoV-2. And then you can have FSGS lesions superposed on other glomerular diseases. Majority of maladaptive FSGS will have a specific causative factor. That is low nephron endowment from unilateral renal dysplasia, or agenesis, or low birth weight, or morbid obesity, or a surgical reduction of renal mass, or reflux nephropathy, which is just another form of acquired reduction in renal mass. And Dr. Rucci discussed morbid obesity last week, although I'm presenting the pathologic classification, it is likely there are disease-modifying genes, and we'll discuss one of these later, APOL1, but there are likely others. And so maybe those 20% of individuals with obesity who are morbidly obese who develop obesity-related glomerulopathy or FSGS on biopsy have variants in genes important to podocyte function that put their podocytes at risk for dysfunction with expansion of the capillaries of the glomerulus or apoptosis. So that's just one caveat to keep in mind. And as we learn more about this disease, I'm sure we will see this. In maladaptive FSGS, again, it's characterized by relative podocytopenia. This can occur by a decreased ratio of functioning podocytes to glomerular tuft surface area, which can be caused by a reduction in the number of podocytes or expansion of the glomerular tuft. And importantly, podocyte depletion leads to glomerulosclerosis. So this is a nice rat model where rats are expressing the diphtheria toxin receptor transgene only in podocytes. So you give the diphtheria toxin to the rats, and only the podocytes are affected. And here you see that with the more podocytes that you kill off, the greater is the degree of sclerosis that's seen on biopsy at day 28. So it's this podocyte death leads to eventual sclerosis of the glomerulus. In maladaptive, the treatment is aimed at reducing injurious glomerular capillary hypertension, and we all do this with renin-angiotensin system inhibition. As we heard last week from Dr. Rucci, in obesity-related FSGS, weight loss and caloric restriction will reduce proteinuria as well. Now moving on to genetic FSGS. Genetic FSGS, as you know, is common in infants and young children. Up to 60% of children with steroid-resistant nephrotic syndrome will have a genetic cause. And in adults with FSGS, the whole exon sequencing can potentially detect pathogenic variants in about 30% of adults with FSGS. Genetic FSGS may be caused by variants in the genes encoding proteins making up slit diaphragm, or any genes that influence its structure, any genes that affect the actin cytoskeleton or its regulation, nuclear function, cellular metabolic pathways, or or adhesion to the glomerular basement membrane. And so far, there's 59, there's probably 62 genes, but in future studies, more will probably be identified. And they may be novel. There might be genes involved in maintenance of the endothelial glycocalyx will have an effect on podocytes, and it will be added to this list. So it really is an exciting time. Many patients with genetic FSGS do respond favorably to RAS inhibitors. And genetic FSGS is, although it's typically resistant to immunosuppression, there are case reports of specific variants in for instance, the gene for epithelial membrane protein 2, or genes that for proteins that interact with Ro-like GTPases that tend to respond to glucocorticoids. And this suggests that glucocorticoids can exert a direct effect on podocyte function. And this has been actually shown experimentally. So this is another model of FSGS, this time in a mouse, where you inject sheep antiglomerular antibody into the mouse develops FSGS, and then when they took the kidney, they're staining for apoptosis here in red, and they're staining the podocytes in green here. The blue is nuclei. And when you see FSGS on the biopsy here without glucocorticosteroids, wherever you see the red and green merge, yellow, you see an apoptotic podocyte. But when you treat with prednisone, the number of apoptotic podocytes are reduced. And some genetic variants may respond to calcineurin inhibitors. And so there's potentially two mechanisms of calcineurin efficacy in genetic FSGS. One is hemodynamic effects, and two is direct effects on podocyte actin cytoskeleton through regulation of the synaptopodin phosphorylation. And to see why this is, all cells are a collection of signaling cascades. And the same is true with the podocytes. But the podocytes, the signaling cascades, interact with the actin cytoskeleton. And we said at the beginning, the structure of the podocyte is so closely tied to its function that if you get signaling cascade interruptions, you can interrupt the podocyte structure and therefore interrupt its function. So nephrin phosphorylation recruits AKT and NWESP to modulate pro-survival signaling and actin organization, respectively. TRPC6 increases intracellular calcium and activates Rho, affecting actin organization and signaling. TRPC5 activates RAC, which affects stress fiber formation and the actin mesh. So all of this signaling is going on. And synaptopodin is when synaptopodin is phosphorylated, it activates Rho and leads to conversion of actin stress fibers. In the presence of calcineurin, what happens is you get dephosphorylation of synaptopodin, leading to degradation of the synaptopodin. This is going to lead to degradation of Rho, which means that you're going to get formation of actin monomers. When you give a calcineurin inhibitor, you get more phosphorylation of synaptopodin, you're going to get more Rho activation, and you're going to get more stress fiber formation. And so now we'll switch gears to FSGS susceptibility genes. And the most famous one, of course, is ApoL1, but a susceptibility gene increases the risk of FSGS when additional genetic or environmental insult occurs. And G1, G2 variants of ApoL1 are the most famous. ApoL1, G1, G2 variants increase the risk of progression in a number of different diseases that involve podocyte injury, such as FSGS, HIV-associated nephropathy, focal global glomerulosclerosis, lupus nephritis, and sickle cell nephropathy. And 2 ApoL1 at-risk variants confers a 17 higher odds for FSGS and a 29-fold higher odds for HIV-associated nephropathy. So if it confers all this risk, why is it still around? And I know almost all of you know it, but as nephrologists, we all should know it so we can explain it to our patients. So I'll just briefly go over it here. So ApoL1 traffics to the trypanosomal lysosome. The acidic pH causes a conformational change in the ApoL1, leading to a channel formation in the channel formation. And that channel formation leads to lysosomal swelling and killing of the trypanosome. In T. brucei, they developed a virulence factor called SRA that inactivates ApoL1 protein. The ApoL1 variants prevent this inactivation by SRA, and therefore the ApoL1 G1, G2 variants protect against sleeping sickness. Now, in normal podocytes, ApoL1 is expressed at very low levels, and ApoL1 knockout are totally normal, and humans without ApoL1 don't have kidney disease. However, there are different triggers that can increase the ApoL1 levels, like type 1 interferons can trigger its synthesis. And this can disrupt, when you have the at-risk variants, disrupt the podocyte structure. And there's 2 mechanisms for how this occurs. One is that in the ApoL1 G0 variant, the C terminus interacts with the ApoL1 N terminus. This frees up ApoL1 to interact with neuronal calcium sensor 1, leading to an increase in phosphatidylinositol 4 kinase beta activity, and this will lead to an increase in phosphatidylinositol 4 phosphate. When that's increased, you get podocyte actomyosin organization, autophagy initiation, mitochondrial integrity, and just preservation of the podocyte structure. However, when you have the G1, G2 variants, that is unable to interact with its N terminus, and thus it interacts with ApoL3, freeing NCS1 and leading to a decrease in phosphatidyl inositol 4 kinase beta activity, leading to a reduction in phosphatidyl inositol 4 phosphate, and that leads to reorganized podocyte actomyosin, autophagy inhibition, and mitochondrial fission, or in other words, the structure of the podocyte is disrupted. So that's mechanism one. Mechanism two is the APOL1 at-risk genetic variants, as we said, can form pores and leak ions across membranes. In the mitochondria, this can activate the mitochondrial permeability transition pore, causing mitochondrial dysfunction and activating apoptosis of the podocytes. So a company actually expressed APOL1 at-risk variants in human embryonic kidney cells and screened a small molecule library for any inhibitors of this ion function, and they found one, VX147. And this is now called inaxaplin. And what they did is they conducted a small single group open label phase 2A clinical study. Inaxaplin was given to 16 subjects with biopsy-proven FSGS and 2 at-risk APOL1 variants with a urinary protein to creatinine ratio of greater than 0.7 and less than 10. And they saw this beautiful reduction in proteinuria over 13 weeks. So hopefully we'll see what happens. The phase 3 study is ongoing, and they're also including pediatric patients above the age of 10. Now, so if it's useful in FSGS by the APOL1 at-risk gene mechanism, might it be useful in other kidney disease with in those with 2 at-risk variants? Well, it may be useful in hypertensive nephropathy, lupus nephritis, sickle cell nephropathy, and FSGS, but we wouldn't expect it to be helpful in diabetes because the 2 at-risk variants does not increase the risk of progression of type 2 diabetes. So the next drug I'd like to talk about is sparsentan, which is as a potential treatment for FSGS. And sparsentan is an endothelial and angiotensin II receptor antagonist. And it was through a rational drug design that an endothelial receptor blocker was combined with an angiotensin II receptor antagonist. And you had chemists just sitting around looking at irbesartan and endothelial receptor antagonists and recognizing, hey, they both have a biphenyl core. And hey, they both have an acetic group at the 2 position of the biphenyl moiety. Why don't we just combine them? And they did on sparsentan. So why test sparsentan in FSGS? Well, RAS inhibitors are known to be effective in FSGS. But additionally, endothelin-1 is produced by glomerular endothelial cells and podocytes. And within podocytes, endothelin-1 activates Rho and PI3 kinases, which disrupt the actin cytoskeleton and the slit diaphragm. So it makes sense. They did a phase 3 double-blind trial of patients 8 to 75 years of age with biopsy-confirmed FSGS or a documented pathogenic variant in a podocyte protein associated with FSGS. They had to have a urinary protein creatinine greater than 1.5 mg per milligram of creatinine and an estimated GFR of at least 30 mils per minute per 1.73 meters squared. And they excluded or tried to exclude patients with FSGS. And it was a beautiful result, right? Everyone was delighted. Sparsentan reduced the urinary protein creatinine over 108 weeks, significantly more than irbesartan. However, there was no statistical change in reduction estimated GFR, kidney failure, or death. So with the reduction in proteinuria, why didn't they see a reduction in decline in GFR? Well, as we stated, FSGS is a heterogeneous disease, And maybe there were some various forms of FSGS, and they only had a genetic cause identified in 20% of the patients. And even if they had a genetic cause in all the patients, you might expect that different genetic variants would respond differently to sparsentan, depending on the downstream effects of the variant. In addition, only 31% of patients had electron microscopy biopsy results. And that's really critical when in a study that they tried to rule out secondary FSGS, because secondary FSGS by biopsy results is generally recognized by segmental foot process effacement. Sorry, that is, so here you see foot processes, and here you see effaced foot process. So that's segmental foot process effacement. It is thought to occur in secondary FSGS. So maybe they had some had secondary FSGS. Other explanations is they saw a greater decrease in estimated GFR at treatment initiation in the sparsentan group, more than in the irbesartan group, and thus they needed more time to see an effect on the, thus maybe they needed more time to see an effect on the estimated GFR decline. That maybe there was a better, they had a better than anticipated response in the irbesartan group, or maybe it's because of the relapsing nature of FSGS, or maybe it's because, FSGS may be a very early marker of future scarring. So maybe an early reduction in proteinuria, maybe you don't see a reduction in progression for more than 6 months or a year later, or there isn't a connection, hard to believe, but there might not be a connection between resolving proteinuria after the disease establishes and reduction in GFR. But this will all come out in future studies, so it is an exciting time. Interestingly, sparsentan was well tolerated, but there was this increase in anemia as a side effect. And the authors of the study, they didn't mention it at all. And I went to the IgA sparsentan trial, and there was also more anemia in the sparsentan arm. So I'm not sure if this is just happening by chance or whether it's real. So further studies will have to show us. So now switching to primary FSGS, which was the impetus of this talk. And so primary FSGS, it has long been hypothesized that there was a circulating permeability factor that damaged the glomerular filtration barrier and led to FSGS. And so this led Gentili in 1954 to take blood from a baby suffering from FSGS and transfuse it into a healthy child and watch the child develop nephrotic syndrome. Now, this type of experiment was more ethically and more IRB approvable. Approvable form was repeated with transplantation in 2012. And in this study, they transplanted a patient with a new kidney. Didn't know why the patient had ESRD, but he was transplanted almost immediately. He started getting a massive increase in proteinuria. They started him on plasmapheresis. The proteinuria increased unabated. The reduction in GFR decreased unabated. And at day 14, they removed the allograft and transplanted into a second patient. And in the second patient, the proteinuria resolves and GFR improves. So the search is on for the permeability factor. And the most famous assay used for this search is one used by Dr. Savin. And she isolates glomeruli from the renal cortex of Sprague-Dawley rats. And these pictures are horrible, and I tried really hard to get better ones, and I couldn't find any. But here is the whole glomerulus. It's this whole thing. This red circle is one capillary, and this is one red blood cells. So they isolate these glomeruli from Sprague-Dawley rats. They incubate and they're isolated in 4 grams bovine serum albumin. They incubate for 10 minutes with different serums, either healthy or FSGS serums, also in 4 grams albumin, and then they switched to 1 gram albumin. If you incubate with healthy serum and you don't perturb the podocytes, what you'd expect to happen is the glomerulus will swell as the capillary swelled, as the erythrocytes was swollen. If you treat with FSGS serum, and that leads to foot process effacement, you increase the permeability to albumin, and you would expect the glomerulus to swell less because the gradient isn't there. So you can actually calculate the permeability to albumin from the changes in the size of the glomerulus. So here's just an example. You can see here when you treat glomeruli with serum from control subjects, you get a nice increase in the volume. When you treat with subjects with FSGS, you don't get as big an increase. And this is again because you have that factor that's affecting the podocytes and disturb, and albumin just leaks out of the glomerulus. And Dr. Savin's group showed that the permeability, the more permeability activity they found, the more likely it was that you'd have recurrent disease. They also demonstrated that as you do a plasmapheresis, the permeability factor decreases. So they had an assay and the search was on for the factor. So a number of years later, they found a putative factor, cardiotrophin-like cytochrome factor, and they isolated this from one of the fractions of a galactose affinity chromatography column, and this fraction caused the same lack of glomerular increase in size of the glomerulus as did the FSGS serum. Interestingly, cardiotropin-like cytochrome factor 1 is a member of the IL-6 family and acts through the JAK-STAT pathway. And when you add it to podocytes, it decreases nephron expression in cultured podocytes. So, this may be it. Again, here we see that the permeability factor, permeability increases when you treat with FSGS serum. When you treat with FSGS serum and add to that serum an antibody against cardiotropin-like cytokine factor, you block the increase, block the increase in the permeability. In addition, when they treated, here again, you see this is the FSGS causes an increase in the permeability to albumin to 0.75. When you pre-treat with a JAK2 inhibitor or STAT3 inhibitor, you block the increase in permeability. So maybe FSGS is due to cardiotropin-like cytokine factor 1. Well, unfortunately, to date, FSGS patients treated with galactose apheresis to remove cardiotropin-like cytokine factor 1 have not improved. So, but the whole story isn't told yet, and even if that's not the factor, there still may be a role for JAK2 and STAT3 inhibitors, and tafasitamab is a JAK inhibitor with some inhibition of JAK2 activity, and it is being treated for an ongoing trial in lupus. So we'll see what happens with this story. The next putative factor is soluble urokinase plasminogen activator receptor. And this is urokinase plasminogen activated receptor is expressed mainly on immune cells, endothelial cells, smooth muscle cells, and it's membrane bound through a GPI anchor, and it's a receptor for urokinase and vitronectin. If you cleave off the GPI anchor, you get the soluble urokinase, the urokinase plasminogen activated receptor, or SUPAR, and that's a soluble form. And what you can see here, SUPAR if you take podocytes and treat them with Supar, you can activate podocyte B3 integrin, leading to an increase in podocyte motility. What Dr. Reiser's group, and he used to be the chief of nephrology in Miami, he showed that Supar is elevated in recurrent FSGS, and recurrent FSGS serum activates beta-3 integrin. So this might have been the putative factor. But another group came along and said, yeah, no, I agree. Supar levels are different in the FSGS group compared to the steroid-sensitive nephrotic syndrome group or the chronic GN group. But they also looked at non-glomerular disease and said, you know, Supar levels are not any different than the non-glomerular diseases, CKD with non-glomerular disease. In addition, estimated GFR was different in the FSGS group compared to the steroid-sensitive group and the chronic GN group. And when you graph, all of the difference in Supar levels could be accounted for by GFR. And when you look at the Supar levels in patients with normal kidney function, they're totally the same. And the final nail in the coffin was injecting mice with Supar resulted in no disease. So this led a group of nephrologists in the Netherlands to propose criteria that should be met before a permeability factor can be considered pathogenic, a so-called Koch's postulates for FSGS. So one, the permeability factor must have biological effects in vitro and in vivo. Two, the permeability factor must be in well-phenotyped patients, but not in appropriate controls, and validated by an independent patient cohorts. Three, there needs to be a temporal relationship between the permeability factor and disease activity remission. And four, in vivo, removal or inhibition of the permeability factor should block the biologic effect. So this brings us to the last putative factor, anti-nephron antibodies. And the recent discovery that you can use B-cell therapies, B-cell targeted therapies in children with frequently relapsing or steroid-dependent nephrotic syndrome, and also in adults, suggested that there was an autoantibody component to minimal change disease. And even though minimal change disease is often thought of as not having immune deposits, pathologists at the Brigham always wondered why they occasionally saw what looked like a punctate staining by immunofluorescence in some minimal change disease biopsies. So if you look here, this is albumin. You see how smooth this immunofluorescence here. But you see here, there's some punctate IgG staining. And just blowing this up equally, you see it here. And they noticed it and always wondered what it was, and they hypothesized that it might be anti-nephron antibodies. And indeed, they saw in a portion of minimal change disease patients that they had anti-nephron antibody detected. These anti-nephron antibody, the activity correlated with disease activity, that when there was remission, that the anti-nephron antibody titer was lower than when the disease was active. And in anti-nephron positive and negative subjects, even though they had similar baseline characteristics, and they similarly had a similar time to remission, those minimal change disease subjects that had the anti-nephron positive sera had a shorter relapse-free period. In addition, what you're looking at here, the MCD5 is a minimal change disease patient who doesn't have the anti-nephron didn't have any detected anti-nephron antibodies. the MCD7 plus and MCD1 plus are minimal change disease patients who did have detectable anti-nephron antibodies in their sera. So they're staining with anti-IgG and an anti-nephron antibody in red, and you see the minimal change disease patient who didn't have any detectable anti-nephron antibodies, doesn't have any co-staining with IgG and anti-nephron antibody. But those two patients who had minimal change disease and anti-nephron sera has lots of co-staining between the IgG deposits and the anti-nephron antibody. And in another group demonstrated that in post-transplant FSGS recurrent, you see anti-nephron antibodies. Further, when you add anti-nephron antibodies, it induces FSGS in mice. You see a large increase in albumin, in urinary albumin. And when you look under EM, anti-nephron antibodies causes foot process effacement, whereas control antibodies do not. So what's thought to be happening is these anti-nephron antibody induces nephron clustering. And what happens is this leads to tyrosine phosphorylation, which causes podocyte foot process effacement and proteinuria. What's interesting is you don't get complement activation, and it may just be where the IgG is in relation that you don't get it, but that's not clear. But you do get complement activation. And I love this story because it reminds me of the H. pylori story, where pathologists all over always saw these strange staining bacteria in ulcers, and only one group thought it was important, and they went ahead and studied it and found H. pylori. So might we have the putative factor? Well, anti-nephron antibodies have been demonstrated to cause proteinuria in vivo and in vitro. It has been validated in different control groups and shown to be not present in other groups like anti-PLA2, receptor-positive membranous, et cetera. So that's there. There's a temporal relationship of the permeability factor with disease activity and remission, so that's there. But we don't have the last one. And just, treating with anti-CD20 and reducing all antibodies is not enough to show that this is a putative factor. So you have to just target the anti-nephron antibody. But I'm sure those things are ongoing, and so hopefully we'll know soon. So in conclusion, I hope I demonstrated that FSGS has multiple causes, that understanding the specific mechanisms underlying FSGS can help guide our treatment, that there is a rationale for non-specific treatment for even genetic forms of FSGS, and that more breakthroughs are on the horizon. And I think for clinical trials in the future, we really need to take into consideration not only the histologic classification, but the pathologic classification. And we really need to do next-gen sequencing for all podocyte-related genes, just so we can really learn something from even the negative trials. So that's all I have. I really appreciate you listening and staying on, and maybe perhaps staying awake despite it being on Zoom, and I'll be happy to take any questions.